You know how sometimes you think you've got a handle on something, and then bam, you discover this whole universe just beneath the surface?
Oh, absolutely, like peeling back layers of an onion.
Exactly. Like you think you know how to make pasta, and then you find out about regional dough variations and specific drying techniques, and it just keeps going deeper.
Hey, yeah, good analogy.
Well, today we're kind of embarking on that kind of journey. We're diving into a world teeming with life. Some of it, let's be honest, it's a little uninvited.
A polite way of putting it.
And our aim isn't just to, skim the surface. We're aiming for that deep foundational understanding, the kind that really distinguishes professionals in this field.
Right, we want you to feel truly well-informed by the end.
Our mission today is to unpack the fascinating, sometimes surprising world of parasitic infections. We'll be drawing heavily from Chapter 221 of your source material.
A really rich source for this.
And the goal, like I said, is to go incredibly deep. Think of it as trying to get you that comprehensive understanding that approaches mastery, almost like becoming an elite professional in this really intricate biological domain, but, through listening to us.
Precisely. And what you can expect from this deep dive is, well, first, a clear and nuanced distinction between the different types of parasites. That's fundamental.
Okay.
Then we'll unravel their often complex life cycles.
Sure.
Some are just mind-boggling. We'll explore the diverse diseases they cause across various organ systems in the body.
Uh-huh.
And crucially, we'll discuss how to approach diagnosing them effectively, which is, frankly, more important than ever in our interconnected world. A patient from anywhere could have been, well, anywhere else.
That's so true. Borders don't mean much to microbes.
Not at all. So by the end, the goal is for you to feel genuinely well-informed, equipped with a profound understanding of these invaders, both microscopic and macroscopic, and the principles to think about them.
And here's a little teaser, something you might find genuinely surprising. I certainly did. Did you know that most of the big multi-celled parasitic worms, they actually don't multiply inside the human body once they're in?
Right, that's a huge point.
It means to get a really severe, debilitating infection, you usually need repeated exposures over time. Keep getting infected from the outside.
It's a completely different biological strategy compared to some of their single-celled cousins, the protozoa.
Yeah, those can just proliferate like wildfire once they get established, right?
Exactly. And that fundamental difference in their, let's call it their business model, is just one of many critical nuances we'll explore. It profoundly impacts how infections manifest and, importantly, how we approach them clinically.
Okay, let's do it. Let's begin by unpacking the very term parasite itself. It comes from the Greek parasitos. Literally means someone who eats at another's table.
Or lives at another's expense.
Yeah.
It paints a pretty clear picture, doesn't it?
It really does. This image of an organism just making itself completely at home, benefiting entirely from its host, without giving anything back.
Yeah. And what's fascinating here is how, by convention, in medicine and biology, this term parasite is specifically reserved for two major groups.
Huh.
Helminths, the worms, and protozoa.
Okay, so not bacteria or viruses, even though they also live at our expense.
Correct. That distinction is crucial because helminths and protozoa are fundamentally different. They're generally much larger, way more complex structurally, and critically, they possess a eukaryotic cell structure. Their cells are organized much like our own human cells, distinct nucleus, organelles, the works, unlike the simpler prokaryotic cells of bacteria.
Right, right. So what does that similarity mean for us, practically speaking, especially for medicine?
Well, that eukaryotic structure, that similarity to our own cells, historically made finding effective treatments incredibly difficult.
Ah, because you might harm the host trying to kill the parasite.
Exactly. Imagine designing a drug potent enough to kill the parasite's eukaryotic cells without causing unacceptable toxicity to our eukaryotic cells. It was a monumental challenge for decades.
I could see that.
But fortunately, thanks to intensive research, modern science, we now have suitable agents, drugs that allow for the safe and effective treatment of most parasitic infections. It's really a testament to progress in overcoming those specific biological hurdles.
That's good news. Okay, so let's talk about the bedrock distinction then. The fundamental differences between these two broad categories, helminths and protozoa. You said understanding this is paramount for mastery.
Absolutely paramount, because it dictates so much about their behavior, how they cause disease, how we fight them.
So why this classification? What's the most important functional difference from, say, a human perspective?
The key distinction, the one that truly dictates their impact within a human host, lies in their ability, or sometimes inability, to multiply within the human body.
Okay, multiplication. Got it.
Let's start with helminths, the worms. These are multicellular organisms made of many cells, like us. Many are actually visible to the naked eye.
Yeah, like those tapeworms you hear about.
Exactly. Tapeworms can be yards long. They fall into two main groups: platyhelminthes, the flatworms like tapeworms and flukes, and nemathelminthes, the roundworms.
Okay.
And some might mature in our gut. Others take these incredible journeys, migrating through tissues after we ingest them or even after they penetrate our skin.
Wow. Okay, but the crucial distinction for almost all of them is
They do not multiply within the human body. Think about that. It means they need specific stages in other hosts outside of us to complete their life cycles and reproduce.
so the practical implication. If you get infected once, that's usually it for that specific worm. The number doesn't increase on its own.
Pretty much. Any increase in the burden of infection, the total number of worms inside you, typically requires repeated exposures, what we call exogenous reinfections. You have to keep getting infected from an outside source.
Which explains why travelers, maybe with just 1 or 2 exposures, are unlikely to get the really severe chronic worm diseases.
Exactly. Their worm burden just doesn't usually reach those critical damaging levels. But if you're a permanent resident in an endemic country, exposed again and again over time.
Then you're far more prone to accumulating heavy, severe infections.
Precisely. That's where you see things like intestinal blockage from massive Ascaris infections, or profound anemia from hookworms bleeding you slowly. These are serious health problems, but they're largely restricted now to those areas of heavy, repeated, endemic exposure.
That's a really profound insight. It totally changes how you think about risk for a short trip versus living somewhere. But you mentioned exceptions to this non-multiplication rule. I bet those are the tricky ones.
You've hit on a key point, and yes, this is a critical nuance for truly mastering the topic. There are rare exceptions that defy the rule. Strongyloids and capillaria.
All right. Strongyloids and capillaria, what makes them different?
Yeah. They're the exceptions that can complete their entire life cycle within the human host. They allow for internal reproduction, autoinfection.
So the infection burden can increase without new outside exposure?
Yes, and strongyloids is particularly insidious. It can persist for decades, maybe causing few symptoms, just quietly replicating.
Decades. Wow.
Yeah? And critically, it's the only helminth we're discussing that can spread widely throughout the body, especially when the immune system is compromised.
Like in AIDS patients or people on certain drugs.
Exactly. In those cases, it can lead to something called hyperinfection syndrome, which is severe and often fatal. Capillaria, while it stays in the intestine, can also reproduce so heavily that it causes serious protein-losing enteropathy, leading to severe malnutrition.
So while most helminths behave one way, these two are distinctly dangerous outliers. Good to know.
Definite ones to keep in mind. Now moving on to protozoa.
Right, the single-celled ones.
These are microscopic, generally much smaller and simpler than helminths. But unlike most helminths, protozoa can multiply within the human body, often leading to potentially overwhelming infections.
Okay, so that's the big difference, multiplication inside us. How do they pull that off? How do they survive our immune defenses?
They have sophisticated survival mechanisms. Some evade the immune response through antigenic variation. Think of it like constantly changing its coat like a master of disguise.
So our immune system can't get a lock on it.
Exactly. Trypanosoma brucei, which causes African sleeping sickness, does this. Another strategy is to survive and multiply inside our own host cells, basically hiding from the immune system.
Which ones do that?
Oh, several big ones. Plasmodium malaria, Babesia, Cryptosporidium, Leishmania, Toxoplasma. They're intracellular specialists.
And the implication for disease severity, is it different for protozoa too?
It is. Often, naive patients, people experiencing their first protozoal infection, are the most severely affected.
Why is that?
Because during recurrent infections, people often develop partial immunity, which can help limit the parasite numbers. Subsequent infections might be milder for some, though not always.
Makes sense. And all that rapid replication, does that cause other problems?
It certainly does. Replication to large numbers in the host promotes the development of drug-resistant forms. We see this acutely in malaria. Drug resistance is a constant evolving challenge, making treatment strategies incredibly complex.
A constant arms race.
Pretty much.
Huh.
And because protozoa belong to so many different biological groups, different phyla, it's often easier to understand them by classifying them based on their primary site of infection.
How so?
We tend to group them as intestinal protozoans, free-living amoebas. Those are the ones you find in water and blood and tissue protozoans. It's a practical classification that helps guide diagnosis and treatment. Gives us a clearer roadmap.
Okay. And one last crucial point you mentioned about protozoa and immunity.
Yes, immunocompromised individuals. They are at particular risk of disseminated infection with the number of protozoa.
We mentioned strongyloids for helminths. Which protozoa are concerning here?
The big ones are Leishmania, Toxoplasma, Cryptosporidium, and Trypanosoma cruzi, Chagas disease. In fact, these specific infections are so significant in compromised immune states that they're classified as AIDS-defining illnesses.
Meaning their presence indicates a severe decline in immune function, like in late-stage HIV.
Exactly. It highlights their opportunistic nature and the danger they pose when the immune system can't keep them in check.
So it really sounds like we're not just passive bystanders or hosts. Our specific role in the parasite's life cycle can fundamentally change how sick we get. It's not just if we get infected, but how and where the parasite develops in us.
Precisely. Connecting this to the bigger picture, understanding whether humans serve as a definitive host or an intermediate host is absolutely key to predicting disease progression and severity.
Okay, definitive versus intermediate host. Let's break that down.
Sure. Humans are the definitive host when we ingest helminth larvae. In this scenario, the larva develops to adult worms, usually within our intestine.
And that's generally milder.
Usually, yes. Often causes mild disease, maybe even asymptomatic. The parasite finds its final home, matures, reproduces, often without causing a huge fuss. There's a notable exception, though. Ingesting late-stage larvae of some somatic or tissue, flukes, can still cause problems.
Okay, but the more serious scenario is when we're the intermediate host.
That's right.
Yeah.
This happens if humans ingest helminth over the eggs.
Ah, eggs versus larva. That's the key.
It's the critical difference. If you ingest the eggs, they develop into larvae inside your body. These larvae don't just stay put in the gut. They penetrate the intestinal wall, migrate extensively through tissues, invade organs.
And that's what causes severe disease, the migration and invasion.
Exactly.
Yep.
Larval invasion of organs can lead to severe debilitating disease because the migrating larvae cause significant tissue damage and trigger major immune responses throughout the body. So the form you ingest larva or egg profoundly determines your role and consequently the potential severity. It's a vital distinction for understanding outcomes.
Fascinating. Okay, let's pivot now and dive into the first major group of helminths. The flatworms, Platyhelminthes. You said these break down into tapeworms and flukes.
Correct. Cestodes, which are the tapeworms, and trematodes, the flukes.
Let's start with cestodes, the tapeworms. They sound impressive structurally.
They really are. They have a distinct head, the scolex, equipped with hold-fast organs, hooks, or suckers to latch onto the host's intestinal wall.
So they really anchor themselves in.
Oh, yes. And then extending from that are segments, proglottids, which mature as they move away from the head, eventually becoming gravid, meaning packed full of eggs, ready to detach and be shed in the feces.
And some can get really long.
Many yards, yes. A long, ribbon-like structure. But interestingly, when we talk about intestinal tapeworms...
The ones living in our gut.
Right. Humans usually get these by eating insufficiently cooked flesh, usually muscle of an intermediate host animal that contains the larval stage.
Undercooked meat, basically.
Yeah. And what's often remarkable, maybe counterintuitive given their size, is that the longest ones developing in our intestine rarely cause serious disease. They're often asymptomatic.
So a giant worm might just hang out.
Often, yes.
Oh.
But there are crucial exceptions and nuances to be aware of for mastery. Take Diphyllobothrium the fish tapeworm.
Okay, what's special about that one?
It has a voracious appetite for vitamin B12. It just soaks it up from our intestine.
Really?
Avidly. And in a small subset of people, about 1–2% of genetically predisposed Scandinavians, it can actually cause pernicious anemia, a serious B12 deficiency. So that's a key potential clinical impact.
Wow. Okay, what else?
Then there's Hominollepis nana. It's unique. It can complete its entire life cycle within the human intestine. No intermediate host needed for it to reproduce inside us.
So it can build up numbers internally?
Potentially, yes. You get it by ingesting infected grain beetles, or more commonly, ova directly from infected humans or mice.
Okay. And the last one you mentioned?
Tadenia solium, the pork tapeworm. Usually you get the intestinal worm from undercooked pork containing larvae, but here's the critical nuance we touched on earlier. If you ingest T. solium ova, the eggs...
From contaminated food or water, or maybe even from yourself if you have the intestinal worm.
Exactly. Ingesting the eggs causes somatic infection. The larvae hatch and invade tissues. That's a totally different, much more dangerous scenario than just having the adult worm in the gut.
Which brings us perfectly to somatic tapeworms. These happen when we accidentally ingest the ova, the eggs, excreted by an animal definitive host.
Correct. Ingesting ova, not larvae, in meat. That's the key differentiator for the severe organ-invading diseases. The larvae hatch, penetrate the gut, and migrate.
What are the main diseases here?
First is echinococcosis, caused by Echinococcus granulosus and E. multilocularis.
How do you get those?
E. granulosus usually comes from ingesting ova from dog feces. The dogs get infected from eating infected sheep or other animal tissues,
Yeah.
common in sheep herders, hunters. E. multilocularis is more subarctic, from ingesting ova from foxes, dogs, or cats that eat infected rodents.
And what happens in humans?
In both cases, the eggs hatch, larvae penetrate the intestine, migrate, and form hydated cysts, most often in the liver or lungs. These cysts can grow slowly over years, becoming quite large and causing problems by compressing organs.
Okay, and the other major somatic tapeworm infection, the one linked back to Taenia solium.
That's cysticercosis, again, caused by ingesting the ova of Taenia solium, the pork tapeworm, not the larvae in pork,
Right, so the eggs hatch, larvae penetrate the gut.
and migrate into tissues, forming cysts called cysticerces. They can end up in muscles, but the most clinically significant and feared location is the central nervous system, the brain and spinal cord.
Neurocysticercosis, I've heard of that.
Exactly. It can cause seizures, headaches, neurological problems. It's a prime example of how ingesting the egg versus the larva leads to dramatically different and potentially devastating outcomes. Truly highlights the importance of understanding the life cycle.
Absolutely. Okay, now moving from tapeworms to the other flatworms. Trematodes, or flukes. You said they're small, leaf-shaped, but size isn't everything.
Not at all. Their size is definitely not a measure of the severity of disease they can cause. And most fluke infections have a distinct geographic distribution, mostly Asia, Africa, Southeast Asia, Pacific Islands. So travel history is, again, paramount.
Okay. Are there intestinal flukes?
Yes, and like intestinal tapeworms, they're usually asymptomatic. Heavy infections might cause some abdominal discomfort or mucus diarrhea, but generally they're less problematic.
So the main concern is with the somatic flukes, the ones affecting body tissues.
That's generally where the significant pathology lies. These also develop into adults after being ingested, but then they migrate out of the intestine into adjacent tissues, causing disease in specific organs.
Like the liver.
Yes, the major liver flukes include Clonorchis sinensis, Opisthorchis species, and Factiola hepatica. You get these by ingesting a larval form, often from raw or undercooked fish or aquatic plants.
And what do they do to the liver?
They live in the bile ducts and are major causes of recurrent bacterial cholangitis, that's inflammation of the bile ducts, often due to obstruction. Over time, they can lead to severe complications like portal hypertension and cirrhosis, liver scarring.
Any of these found worldwide.
Only Fasciola hepatica. It's common in sheep raising areas where animals and sometimes humans ingest contaminated water plants like watercress.
Good to know. What about lung flukes?
Those were primarily Paragonymous species, again, acquired by ingesting larvae, usually in undercooked freshwater crustaceans like crabs or crayfish.
Where are they found?
Globally, except really in Europe. Most cause pulmonary cysts in the lungs leading to chronic cough, maybe bloody sputum. But occasionally they migrate ectopically.
Meaning they end up somewhere unexpected?
Exactly. They can end up causing lesions in the CNS or the abdominal cavity, leading to neurological symptoms or abdominal problems, very different presentations.
Now, on to perhaps the most globally significant trematodes, the blood flukes, causing schistosomiasis. You said this is a massive problem.
Huge. One of the most common and serious parasitic infections globally, affecting hundreds of millions. The main species are Schistosoma mansoni, S. hematobium, and S. japonicum.
And their transmission is unique among helminths.
Very unique. You don't eat them. They're transmitted when free-swimming larvae, called cercaria, emerge from infected freshwater snails and actively penetrate human skin.
Wow, right through the skin and the water.
Yes. Sometimes people get swimmer's itch right after penetration, a temporary rash. Once inside, the larvae find a blood vessel and migrate to their specific target organs.
And different species target different organs.
Yes, and that dictates the disease. S. mansoni and S. japonicum head for the mesenteric vessels supplying the intestines and eventually the liver. There, the eggs they lay cause intense immune reactions, granuloma formation, with repeated exposures. This leads to portal vein obstruction, high pressure in the liver's blood supply, and eventually cirrhosis.
Okay, liver and intestinal problems for those two. What about S. hematobium?
That one targets the veins around the ureter and bladder. The same process, egg deposition, immune reaction, granulomas interferes with urine flow, leads to repeated UTIs, kidney damage, and significantly increases the risk of bladder cancer down the line.
So blood flukes, but targeting very different systems, liver, gut versus urinary tract. Powerful example of specific pathology.
Absolutely. The location of the adult worm and its eggs determines everything.
Okay, incredible journey through the flatworms. Now let's tackle the nematodes, or roundworms. You describe these as non-segmented and bisexual.
Correct, non-segmented bodies. And they have distinct male and female worms, unlike, say, tapeworms, which are hermaphroditic. They represent a huge range of infections, from incredibly common to truly debilitating.
Let's start with the intestinal roundworm. Sounds like a major global health issue.
It really is. The major players are Ascaris lumbricoides, hookworms, Necator americanus and Ancylostoma duodenale, Trichura, whipworm, Enterobius vermicularis, pinworm, and Strongyloides stercoralis.
And the numbers are staggering.
Collectively, they infect maybe 30 to 100 million people, maybe more. Most common in resource-poor developing countries, especially where sanitation is poor, open defecation, use of human feces, night soil, as fertilizer. Those practices facilitate transmission.
How are they transmitted? You mentioned different ways earlier.
Right. Some by ingestion of eggs, the oviducts Ascaris, Trichuris, and Enterobius. Others by active penetration of the skin by larvae, that's hookworms and strongyloids.
Okay. And the severity. You said travelers are usually at low risk for severe disease from most of these.
Correct. Because again, with the exception of strongyloids and capillaria, multiple exposures over time are generally needed for severe disease. Residents in endemic areas face the real burden.
Like the intestinal blockage from heavy Ascaris infections.
Yes, or the severe anemia from heavy hookworm infections due to chronic blood loss. These life-altering consequences are largely restricted to areas of heavy endemicity now.
But let's revisit those exceptions against strongyloids and capillaria.
Yeah.
Because they can reproduce internally.
Exactly. Strongyloids, as we mentioned, can reproduce in the body and persist for decades. And its ability to disseminate in the immunocompromised, causing hyperinfection syndrome, makes it uniquely dangerous.
A persistent, potentially deadly threat?
It is. And capillaria, while it stays in the gut, can reproduce so much that the sheer worm burden causes severe protein-losing enteropathy and malnutrition.
So even without spreading, it can overwhelm the host locally.
Precisely. Now, thinking about life cycles and symptoms, Ascaris and hookworms actually have complex migrations. They go through the heart and lungs before ending up as adults in the intestine.
Lungs, can that cause problems?
Yes. During heavy infections, Ascaris migration through the lungs can occasionally cause eosinophilic pneumonia, sometimes called Loeffler's syndrome, cough, fleeting shadows on chest x-ray, and high eosinophils in the blood.
Eosinophils, those allergy parasite white blood cells again.
Exactly. And finally, pinworms, Enterobius vermicularis. Probably the most common intestinal roundworm infection, still prevalent in developed countries like the U.S.
The one famous for itching.
That's the one. The intense anal and perineal itching, usually at night, from the female worm migrating out to lay her eggs. A very common, if annoying, childhood infection.
Okay, now for the really interesting part maybe. The tissue roundworms. The migratory invaders. These don't just stay in the gut.
Precisely. They migrate to tissues causing very different, often more severe diseases. Broadly, these are the larva migrant syndromes, migrating larvae causing trouble.
And the biggest one globally is filariasis.
By far, in terms of numbers, filariasis affects an estimated 120 million people in tropical and subtropical regions. These are thread-like worms.
And there are different types.
Yes, 4 main species cause 3 distinct diseases. Lymphatic filariasis, caused by Wuchereria bancrofti and Brugia malae. River blindness, caused by Onchocerca volvulus. And loasis, caused by Loa loa, the African eyeworm.
How are these spread?
Humans are the main reservoir, and we get infected from bites of infected arthropods, mosquitoes, or flies, depending on the species.
And the damage comes from?
Larvae develop into adults, which then stay put in specific tissues, lymphatics for lymphatic filariasis, subcutaneous tissue for Onchocerca, and Loa loa. The adults mate and produce next-stage larvae, called microfilaria. It's the migration of these microfilaria through tissues that causes a lot of the damage and symptoms.
Okay. Does it take long to develop severe disease, like the elephantiasis you hear about with lymphatic filariasis?
Yes, that's a key point for travelers. Repeated bouts of migrating larvae and the eventual blocking of lymphatics by adult worms are necessary to get the full syndrome of lymphatic filariasis, like elephantiasis, that grotesque swelling. So it's unusual for short-term travelers, say less than 3 months residents, to develop significant disease. It highlights the cumulative nature again.
Makes sense. What about river blindness?
That's Onchocerca volvulus. Here, the microfilaria migrate through the skin and, critically, the eye. This causes severe skin damage and inflammation, and eventually blindness due to reactions in the cornea if untreated.
And loasis, the eye worm. Is that as bad?
Generally milder. Restricted to Central and Western Africa. Both the adults and larvae migrate through skin and eye. Many people are asymptomatic, often diagnosed dramatically when an adult worm is seen migrating across the white of the eye.
Wow, that would be memorable.
Definitely. Heavy skin migration can also cause temporary itchy red lumps called calabar swellings.
Okay, beyond filariasis, what other major tissue roundworms are there? You mentioned foodborne ones.
Yes, several important ones acquired from undercooked food. First is trichinosis from Trichinella spiralis.
How do you get that?
Ingesting larvae in undercooked pork or other large mammals like bear meat sometimes. The larvae penetrate the intestine, migrate widely, but have a preference for settling in skeletal muscle,
And the symptoms?
muscle soreness, myalgia, caused by the inflammation from the larva and the release of eosinophils and IgE antibodies. You can also get characteristic swelling around the eyes, palpebral swelling, and other allergic-type reactions.
Okay, what's next?
Angiostrongyliosis, caused by Angiostrongylus cantonensis, the rat lungworm, acquired by ingesting larvae, often from raw snails or slugs, or contaminated produce.
And its significance.
It's the most common parasitic cause of eosinophilic meningitis globally.
Meningitis with high eosinophils in the spinal fluid.
Exactly. The larvae penetrate the gut, migrate to the brain and meninges, then quickly die, attracting loads of eosinophils causing inflammation.
Sounds serious.
It can be, but interestingly, although complications happen, most individuals recover spontaneously. The inflammation subsides.
Huh. Okay, what about the other one causing eosinophilic meningitis?
Gnathostomiasis from Gnathostoma spinacerum, acquired from larvae in undercooked freshwater fish or chicken.
And its effects?
Larvae penetrate the gut, migrate, causing boil-like skin lesions, painful eye damage, and eosinophilic meningitis.
Is it worse than angiostrongyliosis?
Though less common, the eosinophilic meningitis caused by gnathostoma is often more severe. It can result in paralysis or even brain hemorrhage. So knowing that distinction is key for mastery, similar presentation, different prognosis.
Got it. Angiostrongylus often resolves, gnathostoma can be much worse. And finally, the success story.
Dracunculiasis, guinea worm disease from Dracunculus medinensis. Acquired by drinking water contaminated with infected water fleas, it has been almost eradicated globally. A huge public health triumph showing what focused effort can achieve against these ancient foes.
That's fantastic to hear. What an incredible tour of the helminths. Now let's switch gears completely to the protozoa, the microscopic, single-celled ones. You said these can multiply inside us, potentially causing overwhelming infections, especially the ones in our gut.
That's right. The ability to multiply internally is the game changer. And with intestinal protozoa, we see a whole spectrum of disease, from acute invasive illness like dysentery to more chronic, debilitating diarrhea.
Let's start with the invasive one.
Entamoeba histolytica. This is the only common intestinal protozoan that causes truly invasive disease. It presents as dysentery, bloody diarrhea. You have to differentiate it from bacterial causes like Salmonella, Campylobacter, Shigella.
How can you tell the difference typically?
Amoebic dysentery usually has a slower onset, maybe less fever than bacterial infections. But the real danger is its ability to disseminate.
Spread beyond the gut.
Yes, through the bloodstream, causing distant abscesses, most notably in the liver. Amoebic liver abscess is a serious complication.
And diagnosis is tricky.
Very. You can't diagnose E. histolytica infection just by seeing the characteristic cysts or trophozoites, the active forms, under a microscope. Why? Because they look identical to a much more common, non-invasive species, E. dispar.
So you need special tests to tell them apart.
Exactly. Specific antigen tests or PCR are needed to confirm invasive E. histolytica, a crucial diagnostic subtlety.
Okay. What about the waterborne risks, especially for immunocompromised people?
Cryptosporidium is a major one here, one of the most common waterborne protozoal infections globally.
Why is it such a problem in water supplies?
It's highly infectious, and its eocysts, the egg-like stage, are very resistant to chlorine disinfection. This has led to massive outbreaks even in cities with treated water.
And in healthy people.
Usually causes self-limiting watery diarrhea. But in immunosuppressed patients, particularly those with AIDS, it can cause severe, relentless, even fatal watery diarrhea, especially if their immune system doesn't recover. It's an AIDS-defining illness for that reason.
What about other common intestinal protozoa, Giardia?
Giardia, Isospora, Cyclospora, and Microsporidia. These generally cause a more indolent course, slower, more persistent, often intermittent diarrhea, not usually acute dysentery.
Giardia is famous for.
Foul-smelling stools, bloating, and styria, fatty, greasy stools due to fat malabsorption. Very unpleasant.
And Microsporidia, you said they're unique.
Yes, they're obligate intracellular protozoa forming infectious spores. In healthy people, may be limited gut infection, but in AIDS patients, they can cause chronic diarrhea, severe wasting, or even spread to the biliary tract or lungs. Highly opportunistic.
Okay, now for the really scary ones. The free-living amoebas. The ones from freshwater that make you nervous about swimming in lakes.
Yeah, these definitely have a high fear factor, found worldwide in freshwater, brackish water, but they cause very different, often terrifying, and rapidly fatal syndromes.
Why are they so hard to treat and often fatal?
Several reasons. Their rapid progression, difficulty in early diagnosis before significant damage occurs, and their ability to directly invade the central nervous system are major factors.
Let's start with acanthamoeba.
Okay. In immunocompromised people, acanthamoeba can cause invasive infection with brain masses and skin lesions. But importantly, everyone is susceptible to acanthamoeba keratitis.
The eye infection.
Yes, a severe corneal infection. Usually follows eye trauma and exposure to contaminated water. It's strongly associated with long-wear contact lens use, a major preventable cause of vision loss.
Wow. Okay, now the really infamous one.
Naegleria fowleri causes primary amoebic meningoencephalitis, or PAM,
How do you get it?
usually acquired while swimming or diving in warm freshwater lakes or hot springs. The amoeba enters the brain through the nose.
Man, the disease.
It causes a sudden severe pus-forming pyogenic meningitis and encephalitis. It's almost universally fatal, often within days. You can sometimes find the motile amoeba in fresh spinal fluid, which is diagnostic.
Man, treatment.
Despite some drugs like miltefosine showing activity in the lab, the CNS infection is almost always fatal. The speed and destruction are just overwhelming, a truly devastating infection.
Grim, is there another one?
Yes, Balamuthia mandrillaris, so far reported only from the Americas. It causes a more indolent, slower developing meningoencephalitis.
Slower than Naegleria.
Much slower. It can cause both inflammation, pleocytosis in the CSF, and a space-occupying lesion, like a mass, in the brain. And worryingly, this can happen even in immunocompetent, otherwise healthy patients. Still very serious, just a different time course.
Right. Okay, moving beyond the gut and environmental amoebas into the blood and tissue protozoans. These cause the really big, globally significant systemic diseases, right? Often with complex life cycles and evasion strategies.
Exactly. This is where we see parasites that have truly mastered living within us systemically, often involving intricate interactions with vectors and our immune system.
And the biggest killer among them is?
Undoubtedly Plasmodium, the cause of malaria. It carries higher mortality rates than any other parasitic infection, still a massive global health challenge.
Spread by?
Female Anopheles mosquitoes in tropical and subtropical areas. There are 6 species that infect humans.
And the species really matters in terms of severity?
Critically, P. falciparum is the most dangerous. Most common in sub-Saharan Africa, responsible for over 80% of infections and over 90% of malaria deaths there.
Why is it so much worse?
Several reasons, crucial for mastery. 1, it can invade any red blood cell, regardless of age, allowing it to reach extremely high parasite loads, hypercytemia. 2, infected red cells become sticky and adhere to the lining of blood vessels, vascular endothelium, causing blockages, organ damage, tissue hypoxia. 3, it's the species most likely to be resistant to antimalarial drugs.
A deadly combination. What about the others, like P. vivax?
P. vivax is dominant outside sub-Saharan Africa. It generally causes milder disease, reaches lower parasite levels, and has less drug resistance. Why? Because it can only invade young red blood cells, reticulocytes, that have a specific surface protein called the Duffy antigen.
And if you don't have the Duffy antigen,
Then you're largely resistant to P. vivax. Many people in West Africa lack Duffy, which is why P. ovale, another cause of milder malaria, can compete successfully there.
interesting genetics. And you mentioned persistent liver forms.
Yes, a crucial treatment point for P. vivax and P. ovale. They form dormant stages in the liver called hypnozoites. These can reactivate weeks or months later, causing relapses. You must treat these with a specific drug, Primakin, to achieve a radical cure and prevent relapse.
Okay. And clinically, malaria presents how?
Variably. Acute fever, chills, sweats, headache. But it can progress to confusion, seizures, coma, kidney failure, lung problems.
Yeah.
Extremely diverse.
So the takeaway is?
You must consider malaria in any traveler or immigrant with a fever coming from a malaria endemic area, regardless of prophylaxis history. Test, test, test.
And the new vaccine.
A significant step, the first against a parasite, targeted against P. falciparum. Currently recommended mainly for children in high-burden areas in Africa due to its moderate efficacy. It's progress, but not a silver bullet for everyone yet. Prevention and treatment remain vital.
Okay. What about Babesia? Also infects red blood cells.
Yes, like Plasmodium,
Sure.
causes babesiosis, often a nonspecific flu-like illness.
Yeah.
But it can be much more severe, even fatal, in people without a spleen. Splenic patients.
Yeah.
Geographically limited, mainly the northeastern and midwestern U.S., spread by the same ticks that carry Lyme disease. Sporadic cases elsewhere.
Right. Now the trypanosomes, flagellated protozoa in the blood.
Yes, 3 important species all have flagellated bloodstream forms but cause vastly different diseases.
Let's start with Chagas disease.
Trypanosoma cruzi causes Chagas disease, found in South and Central America, transmitted in the feces of reduvid bugs, the kissing bugs.
How does the disease progress?
Often an acute phase with mild symptoms or none, then a long latent period, potentially decades, where the parasite multiplies silently inside muscle cells, especially heart muscle and nerve cells, ganglion cells.
And the long-term effects?
Only a minority, maybe 20–30%, develop the chronic organ damage, typically cardiomyopathy, heart disease, and megasyndromes like megaesophagus or megacolon. But everyone infected can transmit it through blood transfusion, organ transplant, or from mother to child. And it's an AIDS-defining illness.
Okay. Then there's African trypanosomiasis, sleeping sickness.
Right. Limited to sub-Saharan Africa, transmitted by the tsetse fly bite. A history of a bite, maybe a painful sore, chancre at the site, is a big clue.
And there are 2 types.
Yes, caused by subspecies that look identical but behave very differently. T. gambiense in West and Central Africa causes a chronic form. Low parasite levels, cyclical fevers for months or years before CNS invasion, and the classic sleeping sickness symptoms.
And the other one?
T. rhodesiense in East Africa, much more acute. High parasite levels, early CNS invasion can cause death within weeks or months if untreated. Highlighting these distinct courses is vital for mastery and prompt treatment.
Very different trajectories. Okay, next up, leishmania.
Leishmaniasis, caused by over 20 species of these obligate intracellular protozoa, transmitted by sandflies, found in almost 100 countries, tropical and temperate zones.
And the disease varies a lot.
Hugely. A wide spectrum. Can be just a self-healing, painless skin ulcer, cutaneous leishmaniasis, or destructive mucocutaneous disease eating away at the nose and palate, or disseminated visceral leishmaniasis affecting the liver, spleen, and bone marrow, causing fever, wasting, and organ enlargement.
What determines the outcome?
Depends on the specific leishmania species infecting, and crucially, the host's immune response. Visceral leishmaniasis is also an AIDS-defining illness. Most cases occur in specific hotspots: India, Bangladesh, Ethiopia, Sudan, Brazil.
Okay, and finally the ubiquitous one, toxoplasma.
Toxoplasma gondii causes toxoplasmosis, found worldwide, extremely common infection.
How do people usually get it?
3 main ways: ingesting oocysts from food or water contaminated by cat feces, ingesting tissue cysts in undercooked meat, or transplacental transmission from an infected mother to her fetus.
And once infected?
After gut invasion, the rapidly multiplying forms, tachyzoites, spread and can invade any nucleated cell. Usually the immune system controls it, and it forms dormant tissue cysts, leading to lifelong latent infection in most people.
But it can cause problems depending on the person.
Absolutely. Clinical manifestations are highly dependent on the host. Congenital toxoplasmosis from maternal infection during pregnancy is most severe if infection occurs early, causing major neurological or eye damage. Infection later might seem okay at birth, but lead to eye problems, chorioretinitis, decades later.
And in healthy adults?
Primary infection is often asymptomatic, or maybe a mild flu-like or mono-like illness, sometimes causes chorioretinitis.
But the real danger is in immunosuppression.
Yes. In AIDS patients or organ transplant recipients, reactivation of those latent brain cysts can cause severe, often fatal toxoplasmic encephalitis. It's a classic AIDS-defining infection, often showing up as ring-enhancing lesions on brain scans. Early diagnosis and treatment are critical.
Wow. Okay, so we've mapped out this incredible, almost overwhelming diversity of parasites and diseases. How on earth do medical professionals figure out what's going on when someone might have one of these? It sounds like serious detective work.
It absolutely is a formidable challenge. And for any disease, really, but especially for parasitic infections, a thorough history and physical examination are the absolute cornerstones. You can't overstate that.
Why, especially for parasites?
Because many of the more serious ones are, frankly, uncommon in places like the US or Western Europe. So clinicians need to have a high index of suspicion. They need to actively look for clues that might suggest a parasitic cause, rather than just assuming it's something more common.
And a huge clue, as we've discussed, is geography. Where has the person been? In our interconnected world, that seems vital.
It's absolutely critical. A detailed travel history, especially to developing nations, is a non-negotiable component of the diagnostic workup.
Does the length of stay matter?
Definitely. The longer the stay in an endemic area, generally the greater the risk, even for healthy travelers. It points towards that dose-response relationship. For some infections, more exposure, more risk.
Are there other factors that increase risk for travelers?
Yes, several big ones. Immunocompromise, as we've repeatedly mentioned, dramatically increases the likelihood of serious or disseminated parasitic infections.
Makes sense.
Also, travelers undertaking adventure itineraries, extensive trekking, close contact with local environments often have higher exposure. Same for extensive travel to rural areas versus staying in urban centers.
Okay.
And unfortunately, involvement in war zones or refugee camps carries significantly higher risk due to the breakdown of sanitation in crowded conditions.
And we shouldn't forget immigrants.
Absolutely not. Individuals who have immigrated from developing countries might present with symptoms or signs related to parasitic infections years, even decades, after their initial exposure. Think about chronic Chagas disease or persistent strongyloids. The infection might have been acquired long ago.
So if someone was careful, took precautions, got shots, took malaria pills, are they basically in the clear?
Not necessarily, unfortunately. It's another layer of complexity. Information on immunization history and adherence to malarial chemoprophylaxis is critical, yes.
How does it help?
Well, for example, if someone has a fever and jaundice, but is fully immunized against hepatitis A and B, those become less likely culprits. If they're immunized against typhoid, prolonged fever is less likely to be typhoid. It helps narrow things down.
But it's not foolproof, especially for malaria.
Exactly. Especially now with increasing drug resistance, even strict adherence to the correct malaria prophylaxis doesn't guarantee protection. Parasites evolve. Now, it is true that most travelers who do get malaria despite prophylaxis were actually non-adherent or took the wrong regimen, but you can't assume.
So prophylaxis history is important information, but doesn't rule malaria out if the symptoms fit.
Precisely. You still need to test if malaria is suspected based on travel and symptoms. Critical thinking is key.
Okay, besides where they've been, the timing of symptoms seems really crucial too, like a biological clock.
It's a critical diagnostic point. First, were they sick while traveling? Did they get any treatment there? That's important context.
And if symptoms started after returning,
The timing relative to their return is key. For example, if a fever starts more than, say, 10 to 14 days after leaving the endemic region, that makes many common, fast-incubating tropical viral illnesses like dengue, chikungunya, Zika less likely. They usually hit sooner.
so a later onset fever might point more towards.
Malaria becomes a higher possibility,
Yeah.
especially species like P. vivax or P. ovale with their dormant liver stages, causing delayed first attacks or relapses months later. Some other parasitic infections also have long incubation periods.
What about traveler's diarrhea? Timing matters there too.
Hugely. Most travelers' diarrhea is bacterial or viral, hits quickly, and resolves relatively quickly, maybe a few days to a week, with or without treatment.
But if it drags on,
Diarrhea that persists for weeks after travel is a major red flag. That pattern is much more likely to be parasitic in origin. Think the Giardia, Cryptosporidium, E. histolytica, Cyclospora. That persistence is a vital diagnostic differentiator. Tells you to start looking for parasites in the stool.
okay, this is where we really try to pull it all together. Connecting the symptoms to specific parasites and where they like to live in the body. This seems incredibly useful for diagnosis, kind of like creating a differential diagnosis based on the affected organ system and geography.
Exactly. And while many symptoms are nonspecific, fever, fatigue, diarrhea can be anything. The combination of symptoms, specific signs, geographic exposure, and timing can powerfully point towards a parasitic cause. As we go through some examples by organ system, think about what patterns or unique features stand out to you. For the full detailed list, Chapter 221 is the place to go, but we'll hit the highlights.
Let's start with the skin. What are some telltale parasitic signs?
Well, that creeping eruption, the serpentine rash where you can almost see a track under the skin, that's often cutaneous larva migrans from animal hookworms, fairly benign. But strongyloids can also cause a rapidly moving rash, larva occurrence, and seeing that in someone potentially immunocompromised is a huge warning sign for impending dissemination.
Okay. What else?
Chronic, intensely itchy skin rashes, especially with nodules, in someone from endemic areas for river blindness, onchocerca, in Africa or the Americas, or painless ulcers that just won't heal, particularly on exposed skin after travel to the tropics or subtropics that screams leishmania until proven otherwise.
Visible worms.
Sometimes. Those migratory skin nodules of Loa African eyeworm or gnathostoma, or the painful nodule, often on the foot or leg, just before a guinea worm emerges. Though thankfully that's all eradicated now.
Okay, moving to the central nervous system, CNS. This is where things get really serious.
Absolutely. Symptoms like profound somnolence, drowsiness, seizures, or coma in a traveler from a malaria zone. You have to think Plasmodium falciparum, cerebral malaria, especially in kids. It's a medical emergency.
What about meningitis?
If it's a sudden, severe, pyogenic, pus-like meningitis after swimming in warm, fresh water, you have to consider the devastating, usually fatal primary amoebic meningoencephalitis from Naegleria.
And those space-occupying lesions on brain scans?
Right. Seizures plus brain lesions. Think cysticercosis, Taenia solium larvae,
Yeah.
in people with exposure from Mexico, Central South America, Africa, or toxoplasmosis, especially reactivated disease in immunocompromised patients, often showing those characteristic ring-enhancing lesions. Acanthamoeba or Balamuthia can also cause brain masses, and sometimes even schistosome eggs can end up aberrantly in the brain or spinal cord, forming masses.
And the eosinophilic meningitis we discussed.
Yes, meningitis with high eosinophils in the CSF points towards Aedes strongylosis. Rat lungworm often resolves, or gnathostoma, often more severe, especially with a history of eating risky foods in Southeast Asia or the Pacific.
Okay, what about the eyes?
Parasites can cause direct damage. Painful corneal ulcers, keratitis, especially in contact lens wearers exposed to water, think acanthamoeba. Gradual corneal opacification leading to blindness in river blindness, onchocerca,
Vision loss.
can happen with toxoplasmosis, either congenitally or from reactivation causing choroidinitis. Toxicara, an animal roundworm, can cause ocular larva migrans, forming a retinal mass.
And the visible worm again.
Yes, seeing that worm migrating across the conjunctiva is classic for Loa, but onchocerca microfilaria can also sometimes be seen in the eye chamber. Gnathostoma can also invade the eye, causing pain and vision loss.
Moving to the lungs.
A solitary pulmonary nodule or abscess could be a lung fluke, perigonomous, especially with travel history to Asia, Africa, or the Americas. And that cough with transient infiltrates and eosinophilia Loeffler syndrome signals migrating larvae of Ascaris, hookworm, or strongyloids.
Heart problems.
Severe malaria, P. falciparum, can cause complications like non-cardiogenic pulmonary edema. But the classic parasitic heart disease is the chronic cardiomyopathy with an enlarged heart and arrhythmias years after infection with Trypanosoma cruzi, Chagas disease.
Okay, the gastrointestinal tract. Lots going on here.
Huge category. Hepatosplenomegaly, enlarged liver and spleen, seek chronic or repeated malaria, visceral leishmaniasis, or advanced schistosomiasis, as Mansonia or S. japonicum, causing portal hypertension.
This liver enlargement.
An enlarged, tender liver, maybe with fever and right upper quadrant pain. Think amoebic liver abscess, E. histolytica. Liver cysts on imaging could be echinococcus, hydatid disease, especially in sheep raising areas. Litter flukes like fasciola can also cause hepatomegaly, often with eosinophilia.
Bile duct problems, cholangitis.
Recurrent cholangitis in someone from East Asia could be clonorchis or opus thorcus. In AIDS patients, cryptosporidium or microsporidia can cause cholangitis.
Diarrhea types, bloody versus watery.
Bloody diarrhea, dysentery, maybe less fever than bacterial causes. Think E. histolytica. Acute heavy cystisomiasis can also cause bloody diarrhea with fever and eosinophilia, Tadayama fever. Watery diarrhea, especially if chronic or persistent after travel. Think cryptosporidium, severe in AIDS. Giardia, foul-smelling fatty stool. Isospora, cyclospora, microsporidia. Capillaria causes watery diarrhea with severe malabsorption and wasting.
Seeing worms.
Passing a large roundworm, 6 centimeters, that's Ascaris. Seeing small white worms around the anus, especially in kids with itching, that's pinworm, Anterobius. Seeing tapeworm segments, proglottids in the stool, that's often Tapetordiania, boo for pork tapeworm. And usually the reason people seek care.
Anemia.
Severe anemia can result from heavy hookworm infection. And that rare pernicious anemia from vitamin B12 deficiency can be caused by the fish tapeworm, the Philobothrium latum, in susceptible individuals.
Okay, nearly there. Genitourinary system.
Itchy vaginal or urethral discharge, very common sexually transmitted protozoan, Trichomonas vaginalis, hematuria blood in the urine, especially with negative bacterial cultures in someone from Africa. Classic sign of urinary schistosomiasis, S. hematobium, can lead to chronic UTIs and bladder cancer.
Muscular system.
Muscle aches and inflammation, myositis, especially with swelling around the eyes and high eosinophilia, strongly suggest trichotillomania from undercooked meat.
And finally, bloodstream manifestations, like fever without obvious localizing signs.
Top of the list always. Malaria, plasmodium. Any fever in a return traveler from an endemic area, period. Also consider babesia, especially northeast Midwest U.S., worse if no spleen.
Huh?
African trypanosomiasis, sleeping sickness, fever, maybe a chancre, swollen nodes, cyclical fevers, eventual CNS signs. Some filarial infections can cause periodic fever with eosinophilia and lymphatic inflammation. And visceral leishmaniasis presents with fever, wasting, and massive hepatosplenomegaly.
Wow. We have taken a truly deep dive today, haven't we? It feels like we've journeyed from these microscopic protozoa that multiply like crazy inside us to the giant helminths with their incredibly complex life cycles, sometimes needing multiple hosts. We've covered this vast, often hidden world.
We really have. It's a huge topic.
And we've seen how understanding their unique biology, how they're transmitted, how they manifest, whether it's a tiny skin rash or devastating organ failure, is just absolutely crucial, especially today with travel making these global connections so immediate and relevant.
You've summarized it beautifully, and it really does raise that important question for anyone interested in health, especially global health. In this interconnected world, what assumptions might we be making? Are common symptoms sometimes masking these complex, maybe rarer parasitic infections?
Right. It requires looking deeper.
Exactly. The nuance of diagnosis is everything. That detailed travel history we hammered home, understanding the host's role, definitive versus intermediate, the significance of symptom timing. These are paramount for professionals aiming for true mastery in this field. It's about connecting dots that aren't always obvious.
So the next time you hear about a mysterious illness, maybe in the news, or even if you or someone you know experiences something unusual after a trip, remember this incredible biological diversity we've explored today. Think about those subtle clues. Where have they been? What might they have eaten or drunk? Even just the timeline of their symptoms. How might a deeper understanding of these tiny, ancient organisms change how we think about health, about global connectivity, maybe even our own place in this grand web of life? We're often just part of their life cycle, aren't we?
Often just a temporary stop or a final destination.
What new questions will you ask after this deep dive? Thanks for joining us.